Here's a quick case study on how I approach right low back pain. I recently dealt with somebody who was dealing with right low back pain, and anytime that comes into my clinic, I am super excited because I know it's going to be really easy to fix. It is almost always an easy fix for me. So I took this individual, we went through the entire PRI protocol to make sure that everything was adding up the way I needed to add up to. Everything looked pretty textbook. This individual was a PEC bilaterally extended. When I see somebody who is dealing with right low back pain, I have a few go-tos. Number one go-to is I need them to be able to shift over to their left side. I know that a lot of their weight, there's a lot of compressive forces on that QL, on that SI joint on the right side. I need to make sure that they can shift over to the left side. I don't think there is any better muscle to activate in this situation than the left adductor. We worked on some easy hip shift stuff. And the other thing that I always want to do, always try to get them into, is I try to get a lot of right glute max because I need to drive them over to the right side. I need the left adductor to be able to pull them over there, but I need the right glute max to drive them back over to the left side. Typically, if I hit those two things, the symptoms go away like that. With this particular individual, it turned out that he was PEC. He was very extended. There was not a lot of mobility in his system. When I tried to do that adductor pullback and get that hip shift, left knee, right knee, try to pull it back to activate that inner thigh on the left side, there just wasn't a ton of mobility there. So what we had to do is, we tried to finesse it a little bit. We tried to make sure that neurologically he was connecting all the dots. And then we went into a little bit of a right glute work to see if we could kind of finagle it without going into the really aggressive PEC down regulation. It turned out that we needed to get into the down regulation of the entire system. So what we did was we did some hanging. We did some what has been dubbed on Instagram as the sleepy sloth, where we put our in a 90-90 position, put a bar up, we're hanging off the bar. It's on my Instagram, check it out. That was able to pull his weight backwards, and we're trying to address the mobility of the situation. We loosened up both posterior hip capsules to make sure that both hips were able to give and receive internal rotation on both sides. And then we did a lot of breathing work. We made sure that his ribs were able to navigate and translate backwards. We made sure that his lower ribs were being able to be held down by his abdominals. He was able to get air out. With PECs, a lot of times they just need to get that air out. Moving backwards was a really big deal for this person. They needed to do a lot of backwards moving, a lot of backwards action in order to get them off their toes, onto their heels, out of this anterior tilt into this posterior tilt, and to translate these ribs back, translate their cranium back, to allow this system that neurological freedom, that neurological permission for all of this mobility. Once that was accomplished, allowing that left adductor pullback, super easy. Allowing that right slide forward for the lift for the right glute max, super easy. Right low back pain melted, super easy. But that is ultimately the entire scope of a typical right. This is probably the most challenging of right low back pain that I see, is when I have to attack them from a PEC bilaterally extended situation. But I'm always going back to the go-tos of left adductor, right glute max. There's of course a few other things that we might want to hit along the way, but as long as they're fairly typical and there's not a lot of pathology in the system, those two actions, making sure that the PEC is addressed first if necessary, if those bases are covered, right low back pain will be a thing of the past.